country. And there were quite a few places that have a lot of experience and resources, and other places that didn't. And so the idea was really to try to collect and curate existing materials. Where there were gaps, we wanted to create materials. We also are focused on piloting some new promising practices, and then doing evaluation and dissemination. And the main areas that we work in are best and promising practices, health communications, health education, online training, and technical assistance, and also the pilot projects. We'll talk a little bit about each of these. Next slide. So one of the things that actually Syreeta helped us build is, we started to think about, like, where do all these different interventions fit? And so we've come up with what we call the journey, the vaccine journey. We also have a similar idea for contact tracing. And at each one of these points are points of potential barriers that we try to focus on and overcome. You'll notice that at the end of the vaccine journey, it goes back to the start. And we're hearing a lot about this right now, which we think it's really key to try to improve the experience as much as possible, because probably the biggest motivator is when somebody has a good experience and goes back and talks to their communities or their friends and relatives, and gets them to take the vaccine journey. Next slide. So we find existing materials and resources, and then try to identify the gaps. So we collect promising practices, and we do this in many different ways. We do it from key informant interviews across the country, listening sessions with major partners or organizations serving refugees, immigrants, migrants. Our partner organizations, obviously, in our community leadership board. We also do news media scans, and we'll talk a little bit about sort of updating our feeds. We do focus groups, some surveys, and then informally through community liaisons that we work with. So we're going to just go through our website, and that's mostly what we're going to do, and then we'll answer questions. So really quick tour. It's kind of broken up into up-to-date activities, events, news and literature, health education and resources, toolkits, training, and then pilot projects. And Syreeta is going to show us a live version later. Yeah, next slide. So next slide. Sorry, you're correct. So we have a page that's up-to-date events, activities, news, and literature. And on this page, we have news that's relevant to RIM populations in particular. We also post some of the activities that we know are going on. And then if there's new literature, medical literature, or other academic literature that comes out, we try to keep that also updated. Next slide. And this is just an example, actually, of some of what it looks like. It's great to have a communication strategist and expert, because it looks really great. And again, this is just an example of some of the material that's there. We also have a health education. We have a translated materials library. And in this library, this has taken a lot of dedicated student time to find all of these. We have over 5,500 materials that are in 175 different languages that we've collected and curated. And it's free of use. So if you look at the bottom, you can select by language, topic, and then the type of resource. So let's say you wanted to pick, let's see, if you wanted to pick Karen language, and you wanted it about vaccines, and you wanted to see if there was a video or a poster, you could search in that way. Next slide. We also, as mentioned, generate some of our own material. So these are some of our own material where we thought that some of the key messages were not currently available. Next slide. Just more examples. We also created something that we call the video booth. And this is kind of a step-by-step instructions on creating your own effective video messages. And beyond the sort of step-by-step instructions, we actually can offer technical assistance to a group that wants to produce its own messages locally. Next slide. And then we also have toolkits. And so what's in a toolkit is, or sorry, we have 5 toolkits, sorry. Yeah, you can go back one slide, Syreeta, sorry. So in the toolkits, we have community engagement, communications, case investigation, and contact tracing, partnerships, and testing. So next slide. So now what's in a toolkit? So what's in a toolkit are guides and checklists that we've created or gathered, I should say. Promising practices, again, either created, but mostly gathered from from around the country for places that are doing things that have been found to be successful, educational materials, and then any additional resources. So next slide. So I'm not going to go through all 5 categories, but I'll just show you a little bit of a sample. We'll use community engagement as a sample for a toolkit. So actually, you can move to the next slide. So community engagement. So these are the guides and checklists. And there's quite a few of these under community engagement. The one I'll point out is the one I like particularly well, which is the bottom one, which is supporting and co-creating meaningful community advisory boards. So this is, just as an example, this is sort of a stepwise process that was put together by a colleague at the Minnesota Department of Health who's been working for years setting up and working with community advisory boards. And so in here, it's advice on how to get started if you've never done it. And a lot of things you wouldn't know about if you haven't actually done a community advisory board, like how do you lay down the ground rules? And how do you select people so they're representative of their community and those sorts of things. And so, so there's a lot of these guides and checklists. You can move to the next slide. More examples, but we'll keep moving. And then we have promising practices. And again, promising practices are mostly kind of curated from around the country where we've identified things that seem to really work and sort of have a little bit of evidence behind them. And then we sort of aim those at different audiences. If you look in here, just to give you an example, there may be places that already do really great work with, say, RIM populations, but they may not have thought of a community movie night, which in some places has worked really well. There are other places that may not have as much experience, and so may need some assistance on vaccine listening sessions, or for their health department, how do you get community liaisons to connect with your communities? Next slide. We also, in this section, help particularly state point out some resources that it's pretty amazing to me that's some say some local or state health departments don't even know they have in their own state, which was like state refugee health coordinators. So we try to connect sort of their own experts within and resources within their states to their programs. We also try to promote, you can see there's a vaccine campaign, partnerships with faith-based organizations, with federally qualified health clinics, and with other community-based organizations. So we try to promote and guide kind of partnerships between those, particularly for places that haven't developed those. Next slide. This is just an example of the vaccine checklist. Again, it's sort of specific. We try to not duplicate everything about vaccines, but more specific about issues encountered in refugees, immigrants, and migrants. Next slide. We also produce online training. So these are on-demand training that are open access. One of the things early on that we found was there's some really great courses. CDC has one, Hopkins has one, ASTO has one that are on contact tracing. We did notice when we went through all those courses early on that they didn't have material that is very pertinent to refugee, immigrant, migrant populations. As an example, there's very little material about how to work with interpreters when doing case investigation and contact tracing. Other things where there was very little on cultural humility and social determinants in health. So we've created some on-demand training that's meant to sort of supplement normal or regular contact tracing courses that are out there. In doing that, we actually interviewed a lot of case investigators and contact tracers, and I don't know if anybody's in that area who's on the webinar today, but one of the things that we noted was there was extraordinary high stress and a lot of burnout, and they were encountering things. So I trained in internal medicine, pediatrics, infectious disease, and I did peds emergency medicine. And working in an ICU or working in a hospital, you get sort of used to trying to answer really difficult questions. For the most part, these case investigators and contact tracers have never had to work at that sort of interface. And so we were finding they were getting questions like, my father died, how do I get his body back to Mexico? And other really difficult questions. And so we thought it was important. We created a stress and resilience module for contact tracers. There's also an accompanying module for supervisors to help to assist with their contact investigators and a case investigator and contact tracer employees. Next. And then we do webinars. And Syreeta, maybe I'll let you mention the upcoming webinars when we get to that your section. Next. And I think this is the point where I'm going to turn it over to you, right? Oh, Syreeta, I think I'm going to turn it over to Hugh here. Is that right?
I think you're muted, Syreeta.
I figured it out. Yeah, I had a hard time finding the unmute button while I was screen sharing. So I am just going to show you a little bit of what we have for our vaccine campaigns. Okay. Thanks, Bill. Technical difficulties. Okay, so I just want to show you a few of the resources that we have related to COVID-19 vaccines. First, I'll talk about Vaccine Central. And so this is similar to a toolkit where you can find resources to support vaccine planning, rollout, knowledge, and confidence among refugee, immigrant, and migrant communities. And so this includes checklists and guides, as well as promising practices from around the country that you could replicate in your own community. We have translations of fact sheets, things like that. So that's all available here. And then separately from these resources, we've developed 3 different vaccine campaigns in support of vaccine confidence. And so the first one I'll talk about is the Get Vaccinated campaign. And we created this one based on feedback that we've gotten that indicates that people from a lot of different communities connect with the theme of protecting their communities. And And so this campaign includes posters as well as social media assets. We have some tips on how to use these products effectively. And these are all currently translated into 29 different languages. We're shooting for 37 or 38, depending on the material. So you'll see more of these links popping up in the next several days. And these are actually customizable. So anyone can remove our logo, add their own logo, change the URL, and even swap out the photo for something that is more culturally affirming to the target audience. Our second campaign is Get the Facts. And this campaign is all created based on CDC guidance, offering facts about COVID-19 vaccines in a way that's a little more simple and memorable, and that counters common misconceptions. And so these facts address costs, ingredients, side effects, eligibility, things like that. And so this campaign includes a social media series of 20 facts that are already optimized for Facebook, Instagram, and WhatsApp. We have a few fact sheets, both 1-page and 2-page fact sheets, as well as a fact sheet for what to do after you're vaccinated. And I'll just show you quickly. These are also, you can just download and post whatever version you want, or if you wanted to customize it, you certainly could. I just wanted to show you how easy that is. You click on the customize link, it'll open up in Google Slides. It's literally drag and drop. You can remove our logo, you can update the URL, and you can even swap out this photo for one of these other ones that are in our image bank. I'll just copy it, paste it here, and it's already sized and ready to go. So we try to make this really easy for the folks who are trying to create materials that are a good fit for their communities. The last campaign I'll talk about is Vaccination Is. And this is a campaign that was created using a community-led hyper-local communication strategy that's developed by and for members of narrowly defined communities. And so for this campaign, we partnered with IDEO.org, which is a nonprofit design firm, to work directly with community leaders to create and disseminate messaging campaigns in support of vaccine confidence. And so this slogan, Vaccination Is, it really acts as an invitation, trying to get us all to think about what vaccination might mean to our communities and demonstrating that there isn't one answer that's all encompassing. We know that unique communities need unique approaches to vaccine confidence that honor their priorities, their values, and the expertise of community leaders. And so for some people, vaccination is hope. For others, it's strength. And for others, it might be a new life. And it's only through this kind of rigorous community engagement process that you can really know what will resonate with your target audience. So we have ready to download materials that support Latino, Haitian, Iraqi, Congolese, Afghani, and the Bhutanese communities. But we also have tools so that you can build your own custom campaign in partnership with the communities you serve. And so we're calling that MakeSpace. MakeSpace is a tool for both public health professionals as well as community-based organizations to make their own customized vaccine campaigns in partnership with local communities. And so it's really a guide that walks you through the process of how to plan, create, and validate your campaign. And this is using the same process that we use for Vaccination Is. And so to learn more about these campaigns, we do have some webinars coming up. One of these repeat currently through the middle of June. And so this is where you can learn more about Vaccination Is, about MakeSpace and our other campaigns, and how to create your own COVID-19 health messages that speak to your community. We have another webinar coming up that is really focused on client-facing staff. And the goal here is to support staff in building their clients' trust and strengthening their ability to answer commonly asked questions about COVID vaccines, while trying to reinforce their safety, dignity, and agency. I know that was a lot. And Ramadan is almost done, but I saw that Bill wanted to speak to that. So we did collect a lot of resources just ahead of and during Ramadan we heard from some of our client contacts that there was some concern from folks that, for example, that taking the vaccine might be breaking fast or other issues. And so we have some videos of faith leaders talking about COVID-19 vaccines from a faith-based perspective, some social media assets that are specifically targeting the concerns of the Muslim community, and then ideas for partnering with faith leaders in your own communities. So with that, I will turn it over to.
Oh, I think you're muted.
Thank you. I wasn't as graceful as Syreeta when she was muted. So a couple of other things that we've taken on. We've taken on an advocacy role, and so we are currently working on various advocacy campaigns as well. And this can include writing some advocacy pieces. But then also, I'm trying to remember the next slide. Let's go to the next slide. Yeah, so something that Syreeta has actually put together for us is, we think writing an op-ed or writing an academic, opinion editorial piece is helpful, but maybe not as helpful as it needs to be in actually enacting some changes. So with Syreeta's help, we actually create an advocacy package. So the example that we just had was for vaccination and farm workers. And if you look at that, we have a blog spot. We published an article in the American Journal of Tropical Medicine and Hygiene, and then to accompany that, we have a blog spot on it. We have this talk to policymakers, so talking points. And then next, we have a section on how to spread the word and how to connect with potential policymakers to advocate for your pieces. This is just an example of some of the work that we've been doing. So the other thing that we have, and you can keep an eye out for this, is we've been working closely with NACHO as we mentioned, and we actually NACHO was given some resources to put out some RFAs, some calls for funding to around contact tracing, testing, education, and vaccination. Those should be coming out soon, and they're really to promote work between local health departments and community-based organizations. There's not many requirements for applying for them, and part of the reason is we want health departments that maybe don't have the capacity to put together really huge grants or have a grant machine to actually apply for these. We think those are the health departments that might need the most assistance. And so the process is going to be fairly streamlined. And then the other thing is we've asked, we provided our resources as sort of a platform. So a health department could look at our resources, decide how they want to use them, and then apply for the funding for that. And then we hope to show that, actually look at some of the evidence around how those work. So next slide. So we're actually drawing to an end here, and then we'll just take any questions or have any discussion that you guys want. This is more on a personal note. I've been, like, as I mentioned, I've been doing refugee health for about 25 years. And working in disparities in health for the same amount of time. And I have to say, in one way, I'm really encouraged because I've never seen the kind of general agreement or level of discussion about trying to decrease disparities and trying to have a more equitable health system. my biggest fear right now is actually not COVID at the moment, but it's actually that when we start to get the COVID under control, and it's no longer a threat to the larger population, we start to see a shift away from this talk about equality in healthcare and addressing disparities. And I think not only will we be judged by history, but we'll be judged by these communities. You know, if the communities feel that we only care about them when it's a threat to, the other people, all this kind of goodwill and work, I think we'll lose a lot of trust. You know, if we're only going to communities when there's a threat, and when it's, you know, if you think about this, and so what we'd like to see is for the NRC to live on, and to eventually start to work in other areas. You know, if you think about, you could put hepatitis B or hepatitis C, you could probably put mental health, you could put diabetes, into all the work into all the stuff you saw today instead of COVID, and it would be just as applicable. And so that's our hope moving forward, is that we can continue this work, and hopefully the broader community and our country will continue to actually follow through on some of these initiatives that are taking place around COVID. This is some of our this is our website. You can also find our newsletter here, and Syreeta puts together an amazing newsletter that goes out every week, that just highlights everything new that's on the website. We don't use it for other things, and so feel free to sign up if you're interested. And I think with that, any last comments, Syreeta? If not, we'll just take questions or questions, comments.
Thank you so much, Bill and Syreeta. That was really, I mean, I know, Bill, we've talked a bunch, and I've been on your website a million times, but just getting that more formal kind of tutorial through everything was really helpful to me. And I know probably was new to some folks on the call. So thank you very much. I see there's some questions for you in the chat, and one of our fearless leaders, Michael Erickson, is on and has his hand up. So I'll just turn it to you, Michael.
Thank you, Ashli, and thank you, Bill and Syreeta. That was incredible. Let me just say a word about who we are, and then if I could ask you just some of the questions I put in the chat were just to understand your context a little bit more in terms of your funding and relationship with CDC. So we are one of the two newly funded prevention research centers at CDC funds. Georgia State and Wisconsin were funded in this current cycle. And from the get-go, we planned on working in Clarkston with the refugee community primarily, and this was all pre-COVID. And then once we got our funding and got our feet on the ground and established our community advisory board, COVID hit, and our direction was shifted to deal with issues around the pandemic, from PPE and testing and other areas. And then recently, in fact, just this week, we received a supplement from CDC for the PRCs for $500,000 to work on vaccine hesitancy and uptake that all of the 26 PRCs around the country have received. We're the only one really dealing with refugees, but all the other ones are dealing with communities at risk, et cetera. So your work is obviously very important and relevant for us, and serves as a model of things that we can not exploit or take advantage of, but to use and to modify and to build on the work that you've already put into it. So that's who we are. But I know that Minnesota has your own PRC, but I assume that you're separate from that. And I was just wondering if you could just talk a little bit about your National Resource Center and there's the supplement that you've received for COVID from CDC, and whether you have any relationship with your Prevention Research Center in Minnesota.
Yeah, so so great questions. And nice to meet you, Michael. And you're we're more than happy to have you explain us as much as you like. Yeah, and I mean the reason that we've created all these materials is because we want them to be used and helpful. And so yeah, and after this, if you have any questions or want any more detail about any of them, like the MakeSpace and things like that, we're more than happy to give you any sort of more specific information. I actually wasn't completely, and it wasn't Ashley's fault, it was my fault. I was not completely 100% clear on who was in the audience today, so that's why we kind of kept it pretty peripheral. So moving forward, definitely let us know how we can be helpful. We actually don't have, and that's something we should with our PRC. I'm sure we overlap in a lot of ways because we're working with the Minnesota Department of Health, but we haven't, we don't have direct connections with the PRC, and it's something that we need to do. Our funding really occurred through, so we've been working for years with the IOM, with the IOM, so the United Nations Migration Agency, and so we had existing contracts to do that work with CDC, and so we received funding, and part of, as you know, in the acute emergency, it was ways to move funding quickly and get things set up. And so this was one way that we could move it. They could move it quickly and get it set up. And Minnesota, and not because of me necessarily, but Minnesota has this history of refugee work. And so the thought was that it would be good to they could move the funds and get something set up relatively quickly here. The big thing for us has been that trying to really have a national reach. You know, we've done that in the past, but this is a whole another level compared to what we've done in the past. So yeah, so that's what we've got set up. And moving into the future, I saw Erica asked about other topics in MakeSpace, and I think I kind of answered that at the end. Moving into the future, I think what we've really set up, I would tell kind of people that I think it's almost like a business, like it's a business platform. Like I don't think of it as business, but it's really a platform that I realize that we've set up over time. You know, it's right now it currently serves COVID, but I think it can serve other diseases and conditions just as well. And I think the key, going back to your PRC question, the key, I think, again, that having worked in this area for so long, is that there's all these microcosms out there of groups or individuals that are working kind of on a local level or in an area. And I think the real trick is how do you pull all these together and then maintain sort of communication across them. So, you know, recently or fairly recently, we'd reach out to the Morehouse. You know, they got the funding, and this was a while ago, but you know, it was well into the pandemic before I even found out that they had funding, and they kind of have a different mandate than us, but there was some overlap there, and so I think, you know, I think it's key, and it's incumbent on us, and we spend a lot of time on webinars or our conference calls trying to make those connections. So yeah, so thanks for that thought. I think, do you know who the person who would be good to contact in Minnesota by chance?
Not off the top, but I know that they're focused on youth, but we can send it to you subsequent about the PI out there and stuff. And I do think we know that they have $500,000 to do vaccine hesitancy and uptake work. I don't know who they're doing it with. We haven't seen their proposal. There's a meeting on Monday with CDC. We'll learn more about the other PRCs, but I think that the time would be right for you to reach out, and we can send you their name after this session.
Yeah, and it may just be my ignorance because we're working with a group called Mini here, who's got a long history of working in refugee communities and has developed a lot of best practices with vaccination in refugee groups, particularly through the the measles issues that we had here. And so they very well could be overlapping with the PRC is my guess, but it's hard to keep track. There's a lot of different people, but I'd love to get that name. That'd be really helpful.
We'll do that. And just to add, and I'll stop, Morehouse is like 2 miles away from us, and we know less about what they're doing than you do. So
Okay.
it's a funny world.
It's a problem sometimes.
So, Bill, it looks like I just looked up the PRC in Minnesota, and it looks like, Michael, as you mentioned, they're focused on healthy youth development. And Renee Seaving is the PI, Sieving.
Yeah,
Okay.
Erica just put it in the chat.
Oh,
Yeah,
thanks.
I think I see it there. Yep, got it. Perfect. I'll cut and paste it here. Thank you for that.
Hey, Ashley, I have a question.
Please.
Thank you. My name's Iris Feinberg. I'm a health literacy researcher and have been doing a lot of work on cultural and linguistic appropriateness, working in our RIM community for the last several years. This is an amazing repository of tools and ideas and things that we don't have to create ourselves. In the health literacy world, we have something called the Health Literacy Toolshed, which lists all of the evidence-based measurements for health literacy, but they're all evidence-based. So if you want to go and use a certain tool, you can go and look and see, okay, what's the domain and who's been researching it and how did they collect the data surrounding it. One of the concerns that I have when I think about our work is with this plethora of tools and resources available, do we know if any of them are evidence-based? Do we know who's using them? Have people been writing about them and documenting their work?
My guess is, since you're an expert, that this is a rhetorical question, because I think you know, you probably know a lot more than I do. But yeah, from our experience, I'll just tell you. So, when I kind of work in population health, and I'm really an infectious disease specialist. But one of the things I love about population health is I'm learning something new every day. Being in this space for a long time, I've been somewhat familiar with health literacy, and as we approach this, kind of the way that at least we approached it was to gather and curate all those resources. We have made decisions, so we have that library that's searchable, but we can't really guarantee the quality of any of those. It's over 5,000 resources, and we can't go out and test them with each community. We have taken down some material that we think is really particularly poor. And we have a little disclaimer on our library that, we can't guarantee the quality of the materials that we're gathering. But given, especially in a crisis, we wanted to make as many of those available as possible. For our materials, we do the materials that like Syreeta was showing you. We do have pretty good processes for those materials, and they include not only like the translation, but there's cultural vetting of those materials by community organization or community and individuals in communities that we have close working relationships with. And then the IDEO, are you familiar with IDEO?
Yes. Yeah.
Okay.
Yeah. I actually help them work on their website.
Oh, okay. So, we've been really impressed with IDEO. I'd always heard that it's kind of that funny thing that, again, not being an expert in the area, even I, not being an expert, just knew there's always been issues. I've worked at CDC long enough and watched all these sort of educational materials being sort of drafted, or I can say Minnesota Department of Health as well, being drafted, within the CDC, and then pictures that people think are probably good pictures for communities, and then somebody goes through and says, well, this needs to be a 4th grade reading level, and then it gets put out to the community without
Right.
community vetting, without, and sometimes those can actually, as you know, can actually do harm because they can miscommunicate, or they just are not as effective. And so kind of the revolutionary thing I think that we're trying to do with IDEO, and I shouldn't say I think we're trying to do, but the thing we've really arrived on is that all messaging is hyper-local, or should be hyper-local, because just because you work with an Iraqi community in one place in Michigan doesn't mean that same Iraqi community is gonna resonate with the same messages in Texas. And so I think what I really like to see again is what we can learn from this crisis as we move forward and come out better. And it's the first time I've seen federal and even at the state level a real focus on how do we craft messages for specific communities. And I think that's where we've kind of moved as a project, is how do we, and obviously, as an individual project, you can't do that. There's hundreds of languages and, thousands and thousands of communities. So how do we provide the tools? And like with the IDEO thing, and again, I'm saying this probably for the benefit of other folks because you probably know this, but all their materials, I kind of, again, a simplified way of looking at it for me is it's kind of like a kid's a sticker book where all their materials are accessible. They're on Google Slides, so if you have a computer, you can access them, and they're very simple technologically. And so the idea is, can you provide the materials for people just to go out and say, what does your community resonate with? Does it, vaccination is what? And then what do you fill that in with? And do you want to use a picture from the library? Do you want to take a picture of a leader in your community and put it on? And so trying to make it easy over time. So I don't know if I answered your question.
You did. We follow much of that same process in developing our materials. We've been working a lot lately making audio-visual animated 60, 90, 2-minute segments on different health topics, including, COVID vaccine and COVID mitigation. And we follow the same process. We work with folks in the community. We spend time having them look at what we've created to make sure that, I learned that, for instance, that Kurdish women don't wear a hijab. And so we had to redo our entire Arabic/Kurdish videos because we needed different characters in them than we did for folks who speak classical Arabic. And then there are even more versions of Arabic. So we are very much engaged and involved in that process. But it's great to have these resources for us to use as a starting place. We fully intend on rolling out materials in the community as applied research. And so we will have at least some kinds of evaluation. Certainly won't be, randomized controlled trials, I don't think. But we will have some kinds of evaluation on effectiveness and efficacy of the materials. And we would love to have a place to share that with.
We'll exploit you, so please feel free to share any materials that you're willing to share broadly with us. We're really happy about that. We do have an evaluation team that's working on various aspects of evaluation for our project. At this point, we haven't really focused their time on individual messages because we're just trying to keep our heads above water, and we're trusting more in the process at this point. There are a couple of things do you know Alfonso Rodriguez from CDC? So I know he's working on a project with CDC looking at the pictures that CDC uses and are those interpreted the way they're are those seen the way they're meant to be seen, and so, but I think moving forward over time, I think that's really key. And again, I think it's going to be really local.
Can I chime in too?
Yeah.
I just wanted to say, specific to the campaigns that I shared today, we do have some kind of aggregate information that, for example, we know that MakeSpace is being accessed by people in 41 states. Or we can say that the individual materials have been downloaded more than 900 times over the course of the last 3 weeks. And so those are some things that we have numbers for. We also have some kind of anecdotal evidence of things working. For example, I know there was a Congolese community where there were some faith leaders who are particularly vaccine hesitant, and folks in the community were looking to them to guidance. And so many people in this particular Congolese community were vaccine hesitant, in part because of inspiration by their faith leaders. And so a group took one of our promising practices and replicated it and brought in some a doctor to talk to the faith leaders and as part of an event. And then after that, it was 70% of the participants walked away from that event and ended up getting the vaccine within a couple of days. And so we don't have like a ton of evidence like that, but we do know that there are some good things happening.
Yeah, I guess I'll add one more little thing is then one of the, as you know, working with communities, the real key is the trusted relationships that develop. And so we have had stuff even that we developed. We had one that was kind of a thorn in our side that was Swahili that we heard back, like, no, like, even though we went through the process and thought it was really good, we heard back, through people, through that trusted connection with the community, that I don't remember what the exact issue is, but no, you need to redo this. And so, there, even if you go through the process, you can still have those issues. And as long, the biggest thing is, does somebody who notices that, can they give you the feedback that you need to fix it?
That's an interesting story and an interesting lesson learned, because right now at that time with that translation, it went through a translation and a proofread, and then we put it out, and it ended up being there's something in the translation that was accurate but very culturally inappropriate. And so they brought it back to us, and we completely changed our process for doing translations. And so right now it is translated by a professional translator, it is proofread by a second translator, it is reviewed by a linguist. And then we have contacts in the community that do a community review for both accuracy and cultural appropriateness. And these are people who don't necessarily have formal language background or education, but it's like, how would a real world person interpret these materials? And they look at both the language, but also the design, the photos we use, and that sort of thing, and they provide that feedback. And so because of what the thing that happened with the Swahili fact sheet, we ended up completely revising our process and putting everything through the multi-step translation validation.
And are community members compensated for the time that they spend helping with translations, et cetera?
Yeah, absolutely.
Yeah.
So that would be, hi, I'm just going to chime in because we have just a few minutes left, and I feel like I want to ask you guys to go to dinner so I can pick your brains for a while. I'm our co-PI with Ashli on community engagement, but just documenting that translation process and putting it and sharing it would be really great as a best practice, because we run into this all the time, even in our own research. And people have to rely on the fact that we say it's not really great to have community members do their own translations, because things can be so variable. So I wanted to write that down while you were saying it.
But if you wanted to have on our website, yeah, we have a couple different guides that I can try to get your email and email it.
That would be great. And then I wanted to kind of back up a little bit and, Bill, ask you a philosophical researcher question. So not even really related to COVID and messaging and communications. We run into in like, for your 20 years in the field with IOM and everything, we always run into the same kind of difficulties when we start talking about doing research. So we're getting ready to do a community needs analysis, and we always talk about sampling and interpretation. And I just wondered if you had any like stories or advice, or like, this is what I've learned, or this is what I think works, or point us in directions of like, these are people who know how to do this well, because we struggle against the same oh, 60 languages, 40 cultures. How are we gonna do this? It's very difficult. And we want to do it well, and we want to do it right. So I was waiting to pick your brain about that.
Well, I could use that. I've only got 1 minute left to try to get out of this question, because I think it's a really hard question. So I will say that I don't have an engagement, so I'm happy to stay on a few minutes extra. And obviously anybody who needs to drop off, please do drop off.
I can stay
I'm happy to continue to answer.
We actually have a meeting right after this to discuss this.
Oh, you do?
So
okay.
Just keep going for a minute.
Okay. Well, you cut us off when you want. So I guess is your question, I'm not exactly clear what your question is.
We run into the fact that even when you do research, having trusted sources is an issue, right? So that's a snowballing sample. And how do we sample effectively different? The community that we serve is so diverse in a very small geographic area. And we want to be sure that we're getting information from all the right parts in a very systematic and reliable way. And we run into these issues and how do we survey, and do we use interpreters, and do we translate the survey into 40 languages, and blah, 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 blah. We go on and on and on about this.
Yeah, and I think you always will. So, and again, I'm nervous. I'm nervous talking to you like I was with Iris, just because I think you probably are a very accomplished researcher, and I think and you're probably an expert in more qualitative or at least community-based research. A lot of what I do is programmatic. So as you know, CDC, and especially with refugees, it's hard for CDC to do formal research. So a lot of times what we're doing is set up more around program evaluation, program research. And I think that's a little different than what you're talking about. And so I mean, I do have experiences with your what you're kind of hitting at. And I think the reason I was kind of joking that you'll continue to talk about it each time is it probably is like, it's resource. It's probably, a lot of it has to do with resources, because the better you do something, the more it costs. And so sometimes you're having to compromise just because, how are you going to access the people that you want to or need to access? And so a lot of it is, a lot of times it's doing focus groups. I've been talking to Ashli a lot about the focus groups and figuring out how, who you're going to get into those focus groups, it's the science of doing focus groups, which I'm relatively new to, and it's the science of how do you reach populations with your surveys who you're most interested in. And so it's almost like, it seems to me it's almost always project dependent, because it kind of depends on what your question is and who your target population is to access. And then once you know what your question is and who your ideal audience is, like, how do you reach them? And then a lot of times that comes down to like what resources you have to reach that specific group. And if you want it to be generalizable, then it's even harder, because then you've got to reach multiple groups and the target population with each one of those groups.
We should have just recorded this so we can play it in our next meeting.
No, I mean, I feel like Mary Helen and Iris and I are all like nodding, because like it's like this is the issue that keeps coming up, which is like, well, what's the budget? Because that determines the methods. Because I think in our pie in the sky, we're doing like a random sample of the Clarkston community in some systematic way. Yeah. And then it's like, well, if we're going to do a random sample, whatever that looks like, that's going to be, so especially when you're dealing with
it was a perfect answer to the question. I mean,
totally.
Ashli and I are all like,
yeah, you're validating our problems. Yeah.
I think I answered the question without answering it.
I think so. We are moving forward with this needs assessment in some way, shape, or form. We do want it to be useful to multiple stakeholders. And so I know because we're, past time, what I would really love is for, us in our next meeting, we're kind of trying to get into the weeds on this a little bit more. I'd love if you're willing for us to share back with you kind of like where we land and, get your feedback, and maybe like Christine and Aaron and anybody else on your team, Bill, that you feel kind of both with respect to content expertise and methodological expertise, any feedback you want to share with us on that plan before we go full steam ahead, we would welcome it.
Yep. Very much.
Very much.
Yeah, no, I would be happy to. Again, I'm really not a subject matter expert on anything, but I'm happy to facilitate. We do have a lot of subject matter experts in various things, and I'm happy to circulate. I'm the same when I do a project. Sort of the more input and the more eyes you have on it, the more things that people catch or good ideas that people have. And so I don't know that we would provide any. I know we wouldn't provide any higher level of expertise, but we, just having different people look at it from different angles might give you some ideas.
Yeah.
The other thing, with your original question, Mary Helen, was the other variable that is so different right now is speed, right? For any of this to be useful, which is usually not the case. You usually can sit and think about, well, what's the best way to do a random sample of this population? What's the best way? And so, but with this, it's like, if you don't get your results quickly, they're probably not going to be useful.
We're already experiencing that with the supplement. Yeah, with what we've anyway, we have to go to our next meeting, but
perfect.
If we get to talk back, that would be great. Thank you so much.
Yeah, thank you.
Thank you for having us,
Syreeta.
Appreciate you guys.
Yes, we really thank you for your time.
Thank you guys.
I'll follow up with another email and just appreciate both of your contributions so much. I learned a lot. I know we all did. So thank you.
Great. Thank you guys.
Okay. Bye.